use examples from the public exam report and just obviously where there's lack of information filled it in, and then tried to ensure that I've got correct answers for you. And it's more not to give you practice questions that will come up in the exam, but to give you an idea of the style of questioning and the level of knowledge that's expected. So Anna is a 22-year-old new patient to the practice. She presents with a discoloured lesion on her fingernail. It's not painful and has been present for a few weeks. Since Anna first noticed it, it's increased in size only a little and moved minimally towards the distal end of her finger. The following image is of her nail. And in the actual exam on the computer, you usually have to click on an image, like you'll see a little small thumbnail and you click on it to make it bigger. The question is, what is the most important next step in management? A, nail matrix biopsy. B, nail trephination. C, reassurance that this will resolve. D, referral to a dermatologist for a second opinion. And E, removal of the nail. Feel free to answer in the chat boxes if you want, but I'll probably just dive right in and give you the answers. So for this one, it's actually reassurance. So you can see that the AKT doesn't ask you what the diagnosis is. They're assessing one extra step of information. So in this question, you've got to realise that the key features on history are that it's been present for a few weeks, it's not painful, it's not increased in size, it's at the base of a nail. So this is a straightforward case of a subungual hematoma, and therefore the management is reassurance that this would resolve without intervention. If it was a new and if it was painful, then you could consider nail trephination. And I think the important thing to recognise that it's a non-sinister lesion, so it doesn't need referral, it doesn't need biopsy, and it certainly doesn't need removal. So I guess that's a nice question, because I think when you're studying, you've got to not only look at a wide range of pictures, resources, ECGs, X-rays. When you're looking at them, it's not about necessarily picking the diagnosis. It's about also knowing that, management steps as well. And that applies to the KFP too. So another example, you've been contacted by the aged care facility your practice looks after to review Joe. Joe is 86 and has developed a sore throat and a cough overnight. The senior nurse in charge tells you he is the 6th patient this week to develop flu-like symptoms, and one resident has confirmed, or should read, has a confirmed case of influenza A. You decide to provide oseltamivir for Joe. What is the most important result of Joe's to review before prescribing him this? Either await his nasopharyngeal aspirate to confirm the diagnosis of influenza A, C-reactive protein or CRP, estimated GFR, full blood picture including the white cell count and differential, or liver function test. So for those playing along at home, the answer is the eGFR. So again, they're sort of asking, not that you know that you need to prescribe Tamiflu for Joe, given he's a nursing home patient, is within the window of time frame for treatment, and given one patient has a confirmed diagnosis, they need to make sure you know how to prescribe it. So in this case, the only thing that would affect your prescription is the eGFR, because you need to dose reduce in patients with a reduced eGFR or chronic kidney disease. It doesn't matter if your CRP is high or normal, or if his white cell count is raised or normal, you're still going to give it to him, and you should know that by the STEM. And again, given that it's a nursing home and there's already a confirmed case and you've got enough symptoms, you wouldn't wait for confirmation. You would try and contain the outbreak by treating any patient with new symptoms. And Tamiflu is renally cleared, so you don't, and it doesn't involve any liver metabolism, so that's not important either. And offhand, sorry, I can't remember exactly which of the public reports these came from, but I tried to pick examples that they said weren't answered particularly well. And I think there was one question from every exam that is available on the website. So we'll just do one more and then we'll have a break for any questions. Dylan is a 23-year-old new patient to the practice. He presents for a sexually transmitted infection checkup. He denies any current symptoms. He has been having casual, protected oral and anal sex with one male partner for the last 12 months. He does not use recreational drugs during sex, and HIV testing 2 years ago was negative. How often should this patient be offered screening for sexually transmitted infections? A, every 6 months. A, every 3 months. B, every 6 months. C, every 12 months. D, every 2 years. Or E, opportunistically. And just while you think about that, I'll just make a note to point out that all the answers in the AKT or the extended match questions are all listed in alphabetical order. So they're in no other order, like they're not trying to trick you into answering in a certain way, they're just listed alphabetically. So in this case, the answer is every 12 months. So you've got some risk factors there for increased transmission of STI in that you have male to male sex. However, then you have risk factors that say he doesn't need it more frequently than every 12 months because he's had one partner, does report using protection, and he doesn't use recreational drugs. Opportunistically in this population wouldn't be appropriate because he has got that one risk factor, but increased screening greater than every 12 months isn't indicated because he doesn't have multiple risk factors. And I've just got I think 3 more examples for the AKT, and then we'll move on to some more info about the KFP. So Rachel is 36. She's a long-term patient of the practice. She's on Levlin and fluticasone, 125 micrograms twice a day, and salbutamol as required and before exercise. She is a non-smoker, and she presents for a regular asthma checkup. On questioning, she reports using her Ventolin on 4 days per week for the last few months. She reports a cough most mornings, but states she has been well otherwise. She uses a spacer for both her puppers, and her technique is assessed as adequate. What is the most appropriate next step in this patient's management? Either add montelukast 10 milligrams daily, add tiotropium 18 micrograms daily, change her fluticasone to fluticasone plus salmeterol, 125/25 micrograms twice daily, or change to fluticasone plus salmeterol 250/25 micrograms twice daily, or increase her fluticasone to 500 micrograms twice daily. I think I might have, in D, I'm not sure if that should be 25/50, but it would be the dose up for serotype. So in this question, it's again one of those AKT questions where it's sort of twofold. So you have to take all that information in the STEM to realise that her asthma is not very well controlled. And if you remember from the table in the asthma handbook, I think there's like well controlled, moderate control, or poor control. And well controlled, they're using their Ventolin less than 2 days a week and don't have any symptoms. Obviously excluding exercise, using their Ventolin less than 2 days a week, or their short-acting puffer. And then in the moderate, like the poor controlled, either mildly uncontrolled or very uncontrolled, they have a list. And if you're mildly uncontrolled, you have 2. If you have very poor control, you've got 3 or more. And in that list are things like having daytime symptoms, using your puffer on more than 2 days a week. And I actually, off the top of my head, can't remember then. But she's only got 2 of them. I think that's the point of this question. So she doesn't have well-controlled asthma because she's using her Ventolin 4 days per week, and she has a cough most mornings, which could also be a sign of poorly controlled asthma. And even there, like I've just added that bit about she uses a spacer and her technique is assessed as adequate. They may not necessarily put information in like that, but they've only given you the options of changing her medications. So although in your head you'd probably get angry and be like, that's not the answer, we need to check her spacer and her technique. If they only give you options, but you just have to choose one that's there. So in this case, the answer is change to fluticasone plus salmeterol 125/25. So as per the asthma handbook, titration of asthma medications guideline, it states low dose RCS that isn't controlling asthma should be increased to a combo RCS LABA puffer at a low dose. And then if it's required to be increased to a high dose from there, you should consider referral and make sure obviously you've checked the puffer technique and everything. So montelukast and tiotropium inappropriate in this setting, and you've got to try a low dose combination RCS and LABA before going to a high dose, which is the salmeterol. And there would be an option to increase the fluticasone on its own, but as per the asthma handbook, they say change to the RCS LABA combo low dose first. All right, a couple more. So Richard is a 48-year-old male. He's previously seen you for minor complaints. Sorry about all the typos. Today he presents with a swollen, painful right knee. He's been renovating his house, which has involved repetitive kneeling. When you examine Richard, he has a tender swelling localized to the anterior part of his knee. The exam is otherwise unremarkable. What is the most likely diagnosis? And that's one of those leading statements that I talked about before. So in this answer, if it said, what is the most important diagnosis, then, I mean, they'd give you a bit of a different stem. But in that case, you'd look at the most significant diagnosis that could affect this patient, and the answer would probably be septic arthritis. Obviously, the stem doesn't fit with that at all, and the lead-in statement says, what is the most likely diagnosis? So given that history of the repetitive kneeling, the swelling is localized to the anterior part of his knee, the answer is D, prepatellar bursitis. So I'm pretty sure in the exam report, they said that patellar tendonitis is also a differential, but it's much less common than prepatellar bursitis. And hence why they asked the question in that way, what is the most likely diagnosis? Although those two conditions may present in the same manner, the more common one is prepatellar. So therefore, by law of probability, that's the answer. And then the last AKT example is Andy, a 56-year-old gentleman, is visiting family in a regional town. He comes to see you concerned about a recent increase in size of breast tissue. He's been diagnosed with benign prostatic hypertrophy and was started on medication to help with the symptoms. He has not brought it with him and is unsure of the name. On clinical exam, you find a moderate amount of gynecomastia equal in both breasts without any breast lumps. What is the most likely cause of his presenting symptoms? And again, reasonably straightforward question as long as you know the side effects of the medication. And I think these questions I've given try to provide an example of the sort of breadth of knowledge that you need to sit the AKT exam. Unfortunately, some of them do require a certain level of depth of knowledge. But I guess you have to sort of know common medications and the common side effects, because in day-to-day practice, you don't have time to look up every single medication and read through every list of side effects. So it's really important to know, you know, the most common and the most significant side effects, I guess, of any medication you prescribe. So in this case, the answer was actually dutasteride, which is B. Commonly, what are they called? The class of medication, filasticide and dutasteride, can cause moderate gynecomastia, which is usually otherwise asymptomatic, so not tender, and there'll be no lumps. And obviously that's medication used to treat BPH.